going to do is, it is a really exciting time, as we've just heard about the CLEAR Outcomes trial, reported top-line results publicly that the primary endpoint was met, and we'll see those data next year. So what I thought I would do is start off by giving you a background to, do we really need any more treatments? How do we potentially, before we complete those trials, ascertain benefit? What is bempedoic acid, and how does it work? And you'll hear in the next talk more about implementation in routine clinical practice. So a list of my disclosures again. So why do we need combination therapy? Well, the answer is very simple. We've seen in clinical trials that lowering LDL cholesterol reduces cardiovascular events, but it's being done through combination therapy. If your baseline, your starting level of LDL cholesterol does not change, but you reset the goalpost to lower levels, you will need combination therapy. That's simple from the maths. And you can look at data, for example, from Da Vinci, which showed us that in Europe, we're using statin-based monotherapy to try and reach those goals. Now, in 2016, when the goals were relatively easy to achieve, we were able, with statin-based monotherapy in 84%, achieve those goals in 1 in 2 individuals. But resetting those goals means that we will fail in 2 out of 3 patients. So that's why we need the combination therapy. So are there any magical properties of these different agents, or is it all explained by LDL cholesterol? Well, with the advent of genetic studies and Mendelian randomization, we can basically look at lifetime differences in LDL exposure achieved through different strategies. Now, that does not mean that when you actually think about an intervention and you put a drug in place, that you basically will get exactly the same benefit, because it may be that when you try to change this through pharmaceutical interventions, you basically have a ceiling of what is achievable, but that's a different question. So here what we've done is we've looked at the target for bempedoic acid, ACLY, way before the cardiovascular outcome trials, HMG-CoA reductase, the target of statins, NCP-101, the target of ezetimibe, PCSK9, obviously the target of MABs, and inclisiran. And you'll see that when you standardize for a 10 mg difference in LDL cholesterol over a lifetime, the effects are exactly the same. So what is bempedoic acid and how does it work? Well, bempedoic acid is a small molecule, meaning you have to take it daily. It works 2 steps up from HMG-CoA reductase on the left-hand side, targeting an enzyme called ATP citrate lyase. Now, because it's in the same pathway as statins, the efficacy of the drug, i.e. the percentage additional reduction, is going to depend upon how much statin you've got on board, low, moderate, high, or even none. The second thing about bempedoic acid is that it's a prodrug. We know many of our patients can't tolerate statins because of muscle symptoms, so the enzyme ACSVL1 that converts bempedoic acid into the active compound is found in the liver, but really not so in skeletal muscle, meaning that some of those muscle symptoms that we see should not actually occur. So what is the clinical evidence for bempedoic acid? Well, so basically this was the LDL lowering development program. At the top, you'll see the 2 studies, the largest of which was CLEAR Harmony, that I had the privilege of leading. And that was on a background of high or moderate intensity statins. And remember, when we double the dose of statins, we only get 6% further lowering, and we often get liver abnormalities, CK elevations, so the level is kind of topped out. A second study was CLEAR Wisdom. The primary endpoints of all of those was really to look at safety, but we also looked at efficacy with LDL lowering over 12 weeks. And then there were 2 trials, CLEAR Serenity and CLEAR Tranquility, looking at patients with statin intolerance. One of those we ran in the background ezetimibe and then added in bempedoic acid compared to placebo. And at the bottom is a fixed dose combination study that I will show you. So this is CLEAR Harmony. 2-to-1 randomization after a run-in of high and moderate intensity statins in people with ASCVD or FH, randomized 2-to-1 to bempedoic acid to placebo. And if you look at the LDL cholesterol levels of these individuals, they're about 108 to 110 milligrams per deciliter. The vast majority of these patients essentially have atherosclerotic cardiovascular disease, and you'll see that the LDLs, despite statins essentially being used, are still very high. So there's a high unmet need. If you look at the placebo-corrected change in LDL cholesterol at 12 weeks, it was 18% lower. But in terms of absolute lowering, that's over 20 to 25 milligrams per deciliter. And you can plot what that would do in terms of cardiovascular outcomes through CTT. These differences were maintained through to the end of the study. In terms of adverse event profile, basically the only thing that you really see is this excess of gout that is explained by competitive reabsorption or prevention of uric acid from being excreted, and that pushes up uric acid levels in some people. So with a prior history of gout, maybe those are people that we should monitor a little bit more carefully, but there was really nothing else that we needed to observe, or that we needed to worry about in routine clinical practice. So on the left-hand side, Clear Wisdom validates that the much larger study, Clear Harmony, with very similar reductions in LDL cholesterol of the order of 17-18% against placebo. But on a background of little or no statin, so now you are working purely by targeting ATP citrate-like inhibition, you get bigger percentage reductions in LDL cholesterol, approaching 28%. So what about the combination, the fixed dose combination? There are some people that won't tolerate statins at all. So would going to a 2-in-1 combination be a value? So this study looked at placebo versus ezetimibe versus bempedoic acid versus a fixed dose combination of bempedoic acid with ezetimibe. So if you look at the middle, go back one. So you'll see basically the LDLs are just below 160. These are people with a high residual risk on the base of their LDL cholesterol. It's a small study, but essentially what you can see is that as compared to the individual components and compared to placebo, you're getting a 38% reduction in LDL cholesterol. So for many people now, we are able to offer this 2-drug combination in one pill, which hopefully will improve adherence. And as we now know, that LDL lowering by a 5th mechanism now will translate into reductions in cardiovascular disease outcomes. And so this actually changes our thinking. We can, for example, use combination therapies. We can use, for example, bempedoic acid with monoclonals or inclisiran. We're doing that in clinical practice. Although statins will be our first-line treatment, many of our patients now will get to goal because we now have another option that is proven to be safe and effective. And with that, I'm going to hand over to the next speaker. Thank you.